hola, guten Tag, any other languages I can't speak. Welcome to the acute kidney injury in COVID-19 patients webinar, part of the ESICM educational series. I'm Professor Lui FORNI from the Royal Surrey County Hospital in the UK, and it's my pleasure to be chairing this session. We've got two very eminent speakers, Professor Eric HOSTE from Belgium and Dr. Marlies OSTERMANN from London here in the UK. So the format will be two 20-minute sessions, and then we'll have questions afterwards, which may well run on over time. As you all know, this has been a devastating disease, and all of us have been affected by it, professionally or indeed personally in some cases. And what's clear is the incidence of acute kidney injury is somewhat variable throughout Europe and the world, and it would be interesting to share some insights and to give us some idea of what the hell is going on, because I think all of us are learning, and although everybody thinks they're an expert, probably no one is right now. So don't be shy to ask questions. I'll be coming up here on my computer screen and I'll be feeding them to the speakers. So as I said, the first speaker is Professor Eric HOSTE, who is surrounded by a very impressive bookcase. So Eric, it's up to you.
Ciao. That's the one I wanted to share. Louis, thank you very much. I'll try to share my screen, but it's one reason or another not functioning now. Yes, probably now it's okay. Another one, sorry for this. Yeah. So my 20 minutes talk will be on epidemiology and etiology of AKI in COVID-19 patients. These are my conflicts of interest, and they are not relevant for this talk. This is a slide from already 6 years ago from Michael Darmon from France, and he nicely illustrated in this study that ARDS patients are at increased risk for developing acute kidney injury, and he found that in his large cohort of ARDS patients, 44% of patients had acute kidney injury. And more recent data from LungSafe, over 2,000 patients were studied in that study, again confirmed this high incidence of acute kidney injury in ARDS patients. So AKI is a very prevalent complication in this in ARDS. However, when we looked at the early papers on COVID-19 patients, AKI was seldom mentioned, and some authors, as in this American Journal of Nephrology paper, even found that AKI didn't exist in COVID-19 in their cohort of COVID-19 patients. So that kind of would be a sad end to this webinar. But luckily, we progressed in time, and we had further publications, including publications on ICU patients only, and in these publications, the incidence of AKI was present. AKI was present, and the incidence varied, but was more or less 6%. 6% of AKI patients in these studies had acute kidney injury, and also 6% of them were treated with renal replacement therapy. But you also notice the huge variation between studies. So there are studies reporting up to 25% use of renal replacement therapy, and others who reported only 5%. Not surprisingly, like in every ICU associated acute kidney injury, patients who have acute kidney injury do worse, and this is nicely illustrated in this slide. COVID-19 patients without and with acute kidney injury, and you can clearly see patients who have acute kidney injury do worse. Of course, this can be explained by more severe illness. maybe worse ARDS, more hemodynamic compromise, more coagulation abnormalities, etc., etc. But probably acute kidney injury in itself plays a role, and this is a adjusted risk indicated in the bottom end of this figure. You can see when you adjust for severity of illness, for age, etc., etc. You can find that AKI stage 2 has an hazard ratio of 3.5 for mortality, and AKI stage 3 has an hazard ratio of 4.7 for mortality. So AKI in itself seems to contribute to this increased risk for mortality. Okay, when we prepared this webinar, we noticed that our experience on the incidence of acute kidney injury was not like that as reported in literature. And we therefore, I asked my friends, critical care nephrologists around the world, if they could spare some time and look at their COVID-19 patient samples or cohorts and look for the incidence of acute kidney injury. And this is illustrated in the next 3 slides. So a big thank you for all you who could find to contribute, and you can see the names in this table. And as you can see, the numbers are all around, starting at 27% in Innsbruck in the center of Michael Ioannidis, up to the 60+% in UK and USA. So that's, and on the bottom of the table it's my center, 85%, but this is AKI defined according to the full KDIGO criteria, so including urine output criteria. And when I only use creatinine criteria, as probably most of my friends did, then we only had an incidence of 15%. So we should be either on the bottom end of the table or on the top end of the table, either way around. AKI stage 1 was not associated with mortality in the previous slide, so we also asked for AKI stage 2-3, the incidence of AKI stage 2-3, and we found that again numbers are varying a bit, but most centers kind of have 1/3 of patients suffering from moderate or severe acute kidney injury, although some centers have a much lower incidence. Look at José Bouchard in Montreal, in Canada, 8%. Again, Michael Ioannidis, 18%. Our center, when you use creatinine criteria, only 4%. So there's still quite some variation. Use of renal replacement therapy. Some centers did not use renal replacement therapy at time we send out the questionnaire. Some centers only have 8-10%, but others, especially in the UK, have 25 to 30+% of their COVID-19 patients on a filter. So that's again wide variation, and that's puzzling. So why is this variation in numbers? There could be an analogy, probably not, but there could be an analogy in the way we're using our PPEs. So the left-hand side is kind of the Ghent way we are using PPEs, and the right that's China, as you can see. So how can we explain this? Let's step back and first think about the mechanisms explaining occurrence of acute kidney injury in COVID-19 patients. COVID-19 patients have a COVID-19 pneumonitis or ARDS, and so the etiology of acute kidney injury in ARDS is also relevant for these patients, and this is nicely illustrated in this graph, which came from the Acute 21 paper authored by Michael Ioannidis and published very recently. And as you can see, there's inflammation generating from the lungs, from the inflamed lungs, causing systemic inflammation and causing organ crosstalk and acute kidney injury. But there's also the effects of mechanical ventilation, leading to increased intra-thoracic pressure, intra-abdominal pressure, leading to hemodynamic effects and untowards effect on acute kidney injury. But there's also something specific to this coronavirus. On the left-hand graph, you can see a coronavirus at the time it enters the cell. And here are the spikes, the S proteins on the outer membrane of the coronavirus. And these S proteins need to bind to the ACE2 receptor and to another receptor, the TMPRSS2 receptor. And this is a protease. And this the binding to these two receptors is crucial for the virus to enter the cell. So these receptors are prevalent in bronchial endothelial tissue, also endovascular tissue, but also in the kidneys. And when the virus enters the cells, it will replicate itself and it will kill the cell. And on the right-hand side, you see the presence of these two receptors in different parts of the kidney. And I indicated where both receptors are most prevalent, and that's in the proximal tubules and in the podocytes. And this is very concordant, very similar to the data that was published on 26 autopsies on COVID-19 disease patients from China. And you can see that on light microscopy, the proximal tubules were affected. There were also red blood cell aggregates in the capillaries. And when you look at the electron microscopy, the gray picture, you can see here the coronaviruses. And if you have a good resolution on your screen, you can also see the little spikes, the S proteins, so typical for this virus. So these viruses were present in podocytes and in proximal tubules. So again, concorded with the receptors distribution in kidneys. So that's one thing. Another thing that's very prominent in these patients is ferritin levels. Ferritin levels, when they are high, there's active disease and patients get worse. And when they are going down, patients are most of the time improving. And ferritin may be the hallmark or the marker of ferroptosis. And ferroptosis is one of the many forms a cell in our body can die. It's an iron-mediated cell death. And so this iron-mediated cell death leads to lipid peroxidation of the outer cell membrane and disruption of this outer cell membrane, and this leads to release of intracellular components into the extracellular space and in the circulation, and this contributes to the enormous inflammation in these patients. So that's also something that's kind of specific for this coronavirus infection, and could play a role in why these patients do worse. So this brings me to my explanation slide. How can we explain the variation in the epidemiology in COVID-related or associated acute kidney injury? Well, there may be differences in baseline characteristics in these patients. If your resources are limited, patients are probably sicker when they enter the ICU. Maybe you're in an area where patients where the population is older compared to an area where the population is younger, so that may play a role. Older population will have more comorbidities that may play a role in the outcome of coronavirus infection. There also may be a variation in practice. This is a new disease, and we are struggling with how to deal with this disease. And it's only since the Gattinoni paper and the webinar that we know that in the initial phase of the disease, the lungs do not need these high PEEP levels. And initially, at least in our center, and I heard from others also, we use high PEEP levels also in the early phases of disease, and which was not necessary. And of course, high PEEP levels contribute to the hemodynamic alterations of mechanical ventilation and have onwards and as such have onwards effects on kidney function. There may be varying degrees of rhabdomyolysis. I understood from Claudio Ronco that this may be more or less prevalent. We didn't notice that much rhabdomyolysis in our patients, but okay, that there may be differences in between centers. You may have a different approach on when you start a renal replacement therapy. Some centers start very early, others have a late timing, so that may explain the variation in the use of renal replacement therapy. There may be a variation in the use of nephrotoxic therapies, and very importantly, there may be variation in keeping the patient dry. And I have a slide on that. So it's since 15 years that we know the results of the FACT trial. The FACT trial was a trial in ARDS patients, and ARDS patients were randomized to a conservative fluid therapy, so a zero fluid balance during the first 7 days of treatment, versus a liberal fluid regimen, and these patients had 7 liters plus after 7 days of treatment. And the conservative randomized patients did better on ventilatory outcomes. So they had more ventilator-free days, and they were also shorter. They had shorter time in the ICU. And the fear, of course, was that this dry strategy would lead to more acute kidney injury, but the contrary was true. As you can see, there was less use of renal replacement therapy in the patients that were kept dry. This was not statistically significant, but okay, there was a clear signal. Let's call it like that. And we know that the guidelines on COVID were, especially in the early, 1 month ago, to keep the patients dry, to protect the lungs from developing too much of alveolar edema. And I heard from colleagues in Paris and UK also that they had a lot of admissions in the ICU directly from the emergency department, and some of these patients were already fluids dehydrated on beforehand, probably because of fever and because of gastrointestinal symptoms. And when you have a dehydrated patient and you keep him dry and you apply high levels of PEEP, that's something the kidney doesn't like. So we now use a more intelligent approach, and we look for signs of volume status. And if a patient is dehydrated, especially in the first phase of the disease, we will look for optimization of volume status and not keep them as dry as possible. A last item that I would like to discuss is that there's maybe specifics to the SARS-CoV-2 virus that can explain why there's variation in the incidence of acute kidney injury. And this is something that came in my mailbox just this morning. It's a publication in JAMA explaining or discussing the relation between COVID-19 and African Americans. And in the US, African Americans are taking up a higher proportion of ICU patients are African Americans, and they also have a worse prognosis. And I learned from the UK that in their ICUs, a large proportion of their patients are from Asian backgrounds. So there seem to be ethnicity may seem to play a role, or probably plays a role. And there's some science behind that could explain this. On the left-hand side, you see a slide from Joris de Lange, and he nicely illustrated the correlation between the ACE polymorphism that exists in the population. So the ACE1D allele is in some ethnicities more prevalent and in others less prevalent. And as you can see in cohorts where this ACE1D allele is less prevalent, the incidence of a COVID-19 cases per million population is higher compared to the other way around. So that could explain why some patient groups, some ethnicities are getting more sick from COVID-19. And in relation to the kidney, there's also some variation in these specific receptors. So the ACE2 and TMPRSS receptor is not evenly distributed among Occidental patients from Occidental origin and Asian origin, as you can see in the right-hand part of the slide. So this brings me to my summary slide. The incidence of AKI in critically ill COVID-19 patients in literature is rather low, 5%. Patients on average are reported with AKI, and 5% are treated with renal replacement therapy, but there's some variation. But when we use real-world data from the friends around the world, we found that moderate and severe AKI, so AKI stages 2 and 3, occurs in 20 to 30+% of patients, and 25 to 30% of patients are treated with renal replacement therapy, with variation among centers, as I explained. Not surprisingly, we also found for COVID-19 patients that acute kidney injury was increasing mortality, so it contributes to the mortality of these patients. The etiology of acute kidney injury in COVID-19 patients is similar to that, is probably similar to that in ARDS patients. So there's hemodynamic components, there's the impact of mechanical ventilation, and this will impact cardiac output, fluid management, high CVPs. These are all elements that contribute to a higher incidence of acute kidney injury. There's also marked inflammation, especially we know now that in the second and third phase of the disease, inflammation is taking over from viral load, and inflammation is very prominent in these SARS-CoV-2 patients. But there's also inflammation generated by mechanical ventilation and inflammation generated by the diseased lungs itself, the ARDS. And as an extra, the virus is damaging organs and cells, including the kidneys, and this especially in the proximal tubules and the podocytes. So the variation in incidence can be explained by differences in patient cohorts, but there's also maybe a difference in ACE polymorphism and receptors in different ethnic groups, which may explain why certain patient groups have a higher incidence of severe COVID-19 and a higher incidence of acute kidney injury in this disease. And this brings me to my final slide. Thank you very much.
Okay, Eric, thanks very much. I feel like I should be clapping, so I'll do that for the international community. That was an excellent overview of a difficult subject, really, because there's a lot of conflicting reports from around the world, and it's useful to try and get some information to help our practice now, but it's trying to dissect the information to get to the truth. So we have got quite a few questions from the audience, which is encouraging because it means that somebody apart from me is listening. Who text me. So what I'll do, Eric, I'll just ask some of these questions before we run into Marlies sussing. And this one's a clinical question, really, and it is something that occurred to me when we discussed this before. But someone has asked, I can't say who it was because I don't get the names, but what markers do you use to assess the volume in patients with COVID cases, and what threshold do you use?
Yeah. We tend to evaluate volume status really clinically. So passive lag race, eyeballing of the arterial line, all these things. And it's only in very severely hemodynamic compromised patients we are using invasive monitoring, and that can either be a Swan-Ganz catheter or a PICO. That's similar to what we do nowadays in sepsis patients. capillary refill, of course, also we are also using that. So most of the time we use clinical signs. Yeah. Apart from that, of course, the lab signs, lactate evolution, lactate going down, lactate going up, blood pressure, urine outputs, all these things contribute also, of course, to this clinical assessment of volume status. That's how we do it.
Yeah, and I concur with that. That's almost exactly the same as us, apart from the fact we don't use PA catheters. It's interesting that throughout our careers, we started off as being numerical wizards, looking at numbers, and then we turned into doctors again, which is quite reassuring, really. So I hope that answers your question. It's a bit of medicine. Now, we've got some other questions. One's a comment, really, which was someone has said that in 80% of AKI that he has seen, or she has seen, they thought it was secondary to the use of antivirals and drugs. What do you? And I know the Chinese post-mortem data showed some evidence of acute interstitial nephritis. Have you got any comments on that, Eric?
Yeah, it's possible. I don't have that experience, but it's remdesivir. I think there was a paper that there was some AKI as a side effect. So that's really possible. In our ICU, we randomize patients to anti-inflammatory therapy. So the antiviral therapy is restricted, let's say, to the early phase of the disease, and we don't see them in our ICU. They are on the cohorts, the normal wards, let's say. So I don't have personal experience on that. Yeah.
No, and again, I've got to agree with you, because we don't use them by the time they're on the ITU. We're not using them. There are some studies going on which will use an antiviral arm in the UK, so I may see some in the future. Another question, which will in some ways lead on to what Marlies will be talking about, or what I hope Marlies will be talking about, is there any evidence on biopsies, for example, of micro or macro thromboses? So, within the kidney.
Well, there was a case report today in New England on TTP. So it happens apparently, but is this? Yeah, there's many. So is this TTP caused by COVID-19, or is it two diseases happening in this one patient? I'm not sure on that. Thrombosis is happening, and it was also present in this biopsy series in China. So there was capillary thrombosis. And we also notice that these patients are very thrombogenic, and we are increasing our prophylactic dose of low molecular weights, and we are struggling with anticoagulation in these patients in general. And Marlies will address that. I guess because it's a big issue in RRT. So yes, thrombosis is present. It was in this 26 patients series markedly present. Yeah, okay, that's the answer. Yeah, sorry.
That's all right. Well, that's excellent, because that segues brilliantly into the next talk. So you can see ace moderator that picked. So Eric will stay online, no doubt, and join us for the wash up at the end. So it's with great pleasure that I welcome Dr. Marlies Ostermann, who I'm sure many of you know. I'm hoping, there she is, which is a relief. So Marlies, I hope is going to talk to us. Sorry, I was slightly distracted because it says Marlies Ostermann, Belgium. So I don't know with the lockdown how you've managed to get to Belgium from London, Marlies, but hopefully you're still in the UK. That's for my sake and for your patients. So Marlies, if you could take it away, that would be fantastic.
Thank you, Louis, and thank you to the ESICM for the invitation to take part in one of the many COVID webinars. It's a great honor. And following on from Eric's excellent talk, I will address renal replacement therapy as obviously the treatment for severe advanced acute kidney injury. these are my disclosures, and they have not affected what I'm going to say. So we're clearly dealing with a new medical illness. Some of us have been dealing with it for a few months, and people like me only for the last few weeks. And we're all learning new things every day. And when it comes to renal replacement therapy, the question is whether we should do anything different from what we normally do, or whether people with COVID-19 infection strategy to provide renal support. If you go to the literature and you go to the very recent Surviving Sepsis campaign guideline, they have a lot of information how to manage patients, but with regards to renal support, there is no mention. Similarly, if you go to the guideline from NICE, the National Institute for Health and Care Excellence in the UK, published less than a month ago, again, renal support was not mentioned. Finally, if you go to the very latest guideline from the National Health Service here in the UK, published last week, they touched on renal replacement therapy, mainly because it had become clear that this was a challenge in clinical practice. And the guideline, as stated here from last week, essentially recommends standard renal replacement therapy. However, they make a note that clinicians had feedback that filters didn't seem to last as long as they were used to. But in terms of actual renal support, the recommendation was standard renal replacement therapy. So what is standard renal replacement therapy? Well, it's essentially all the types of modalities which we are used to. So continuous extracorporeal renal replacement therapy in the form of continuous hemofiltration or continuous hemodiafiltration, various forms of intermittent renal support from standard intermittent hemodialysis to prolonged intermittent renal replacement therapy, which obviously can be delivered with a standard hemodialysis machine, but also with a standard CRRT machine. And then another type of standard renal replacement therapy is obviously peritoneal dialysis. And again, there are different types. So the NHS guideline here in the UK recommends that standard renal replacement therapy is recommended for patients with COVID. And this means that our normal decision-making process of choosing a modality for the patient in front of us probably still applies. We have different types, we have different modalities, and they have advantages and potential problems. And clearly, as outlined here, with any form of intermittent hemodialysis, you get a lot of clearance in a short period. You remove fluid in a shorter period. Patients are exposed to the renal therapy for a shorter period, but obviously at the expense of having fluctuations in are connected to renal support continuously with the advantage of having more continuous and static and stable control. So is there anything specific in patients with COVID-19 infection? Well, these are often patients when admitted to the intensive care unit who either need to be intubated or are attached to a ventilator, but often, as we've now recognized, often also develop other medical problems. They may develop vasodilatory shock and need vasopressors, and a proportion of these patients develop severe hyperinflammation, where they become very pyrexial and hemodynamically sometimes unstable. And I propose to you that these are patients who, in an ideal situation, we would treat with continuous renal replacement therapy, as advised by the KDIGO guideline. And if available, then we usually tend to start before patients have life-threatening complications. We adjust the dose and compensate for potential unplanned episodes of filter clotting or any other forms of downtime. We choose an anticoagulant which provides optimal filter patency. And in a lot of units, we are very fortunate having highly qualified staff with appropriate training, striving to achieve a high standard. A lot of people have now seen that things have changed during the COVID-19 pandemic. And a lot of clinicians are now facing new challenges where the resources may be limited, supplies of usual kits are no longer available or reduced, where they are looking after patients and working with less qualified staff, sometimes surge staff who've never worked in the intensive care unit before. They may also find themselves looking after patients outside the intensive care units, so in very unfamiliar environments. And as already alluded to by the recent guideline, a lot of clinicians have reported that the usual therapy suddenly gives challenges. So normal practice is no longer working. Filters seem to clot earlier than before. So are there alternatives then, especially in light of the fact that some of clinicians are faced with suddenly with a much larger population and often with larger intensive care units expanding outside the usual intensive care unit, where they suddenly need to treat more patients than they're used to. An alternative is a form of intermittent therapy. And obviously, as we said, this can vary from standard hemodialysis, which is usually around 4 hours, to a prolonged intermittent treatment, ranging from 6, 8 to 10 hours. With both techniques, we need machines, either need a standard hemodialysis machine, or if we choose to use our CRRT machines, again, they can be programmed to providing treatment for 6 to 8 hours. In both cases, we need fluid. We either need fluid as provided by our reverse osmosis system, or we may need fluid, dialysis fluid, commercially available in bags, or we may find ourselves in a unit where we generate the fluids ourselves. But we need fluids to provide standard intermittent extracorporeal renal support. In terms of anticoagulation, with a standard hemodialysis session for 4 hours, we may get away without anticoagulation, but the longer the patients are exposed to renal replacement and the kit and the circuit, the higher the need for anticoagulation. In order to provide intermittent renal replacement therapy, we certainly need staff, and we can either train our own staff or we need some staff and help from the renal unit. But some extra and trained staff is required. But the advantage of the intermittent modality is that more patients can be treated during a 24-hour period. And depending on how short the session is, more patients can be treated. And then lastly, if CRRT is not an option and an intermittent modality is also not an option, we shouldn't forget that acute peritoneal dialysis is a perfectly acceptable form of renal replacement therapy in many countries. For those of you who are less familiar with acute peritoneal dialysis, just a reminder, it's a form of dialysis where we use the peritoneal membrane to remove solutes and water. To do this, patients have a catheter inserted into their peritoneal cavity. We then use the peritoneal membrane to facilitate the exchange and the removal of water and solutes. And after a period of 3 to 4 hours, the dialysate, the effluent is drained out again, now containing some of the toxins and electrolytes and waste products. Once drained out, new fluid is inserted and instilled and remains in the peritoneal cavity for another couple of hours. different forms of peritoneal dialysis, but on average, patients have 2 to 2.5 liters of fluid instilled. And just for completeness, this can be done without a machine, so where the fluid is instilled and removed manually, typically known as continuous ambulatory peritoneal dialysis. But it's also possible to use machines which can facilitate this exchange and move fluid in and out whilst the patient is asleep. So these are the standard types of renal replacement therapies. With regards to extracorporeal renal support, acute peritoneal dialysis certainly has some advantages and therefore needs to be considered when we talk about renal support for patients with COVID-19. It provides continuous renal replacement therapy. We wouldn't need a dialysis or CRRT machine. There's no need for any anticoagulation, and there's no need for vascular access. But again, like any other therapy, there are potential risks and disadvantages. Patients need access to the peritoneal cavity, so a peritoneal catheter is required. Some form of kit is necessary, and the type of dialysis and fluid removal is less precise because we can't dial in the amount of fluid to be removed. Clearly, some training and education is necessary, and although there is no risk of vascular problems or bloodstream infections, there's a clear risk of other infections like peritonitis. And for COVID-19 patients in particular, it's important to acknowledge that there is a risk of an acute leak, especially if patients need to be nursed in the prone position. So we have different types of renal replacement therapy available for patients suffering from COVID-19. The challenges in comparison to many other critically ill patients we're used to looking after are that this is a group of patients with a new disease, which we are only just about trying to learn about and trying to understand. It's still new to the majority of us. The data are still based on expertise and observation, but not enough research has been done because it's clearly a new disease. Clinicians looking after patients with COVID-19 have reported severe hyperinflammation, hyperpyrexia, and vasodilation in a proportion of patients. And they've also noted that patients are very prone of the DVTs, a high risk of pulmonary emboli, and a high risk of vascular thrombosis, including thrombosis of the renal circuit. In a lot of units, patients and clinicians are challenged by the fact that there are suddenly more patients in their units and more patients needing renal replacement therapy. So the resources may be very limited, and clinicians are forced and asked to adapt their plans. They have to adapt their plans because the environment has changed, because resources and supplies are limited, and because the staff has changed in a lot of units. Non-ICU staff is helping out. Everybody is asked to adopt new techniques and learn rapidly how to look after these patients. And understandably, there's already a level of stress at the bedside. Adding renal replacement therapy to the care of a patient undoubtedly increases the level of stress. There's more physical stress, especially for people at the bedside wearing personal protection. It's hot and it's harder to hear, and the environment is generally more stressful. At the same time, everybody is asked to step up and adapt quickly, learn rapidly, and is asked to provide a level of care to the highest level if possible. And as clinicians, we are in a situation where we are learning a new disease and at the same time would like to try to understand the disease as best as we can and do some research during already very busy times. So what can we actually do? Being in London, being in the middle of the COVID-19 pandemic and dealing with a large number of patients who need renal replacement therapy, for me, the most important thing has been to work with a new group of people. And I was very encouraged to see there were so many clinicians and colleagues available who actually had a lot of expertise. And finding the expertise around you and learning from each other, learning from renal colleagues and pediatric colleagues and anesthetists has been a fantastic experience, because solutions can be found. With regards to equipment and consumable, it's important to take stock and explore what is actually available. When certain machines run out, it's important to know what alternatives are available and how many, for instance, intermittent hemodialysis machines are available in the hospital, in the renal unit, in the pediatric unit, in the pediatric ICU, for instance. It's also important to look at alternatives like acute PD and the number of machines available. In the last 3 weeks, I've learned a lot about the hospital. I did not know where we had access to pumps and access to reverse osmosis units. And this has been enlightening, encouraging, and also, again, offered new opportunities. And then finally, when stocks run low, it's important to look at other ways of delivering dialysis and look at colleagues in other hospitals in other countries and see how they deliver dialysis and how they acquire, for instance, dialysis fluids in times when commercial fluids are not available. Lastly, it's clearly important to select your patients carefully. And certainly in our unit, we have changed our selection criteria, and we have changed our indications for starting renal replacement therapy. And we've changed our selection and identified those patients who may be suitable for intermittent renal in the intensive care unit. And lastly, we're looking at ways of reducing the use and need for continuous renal replacement therapy. So for instance, as I've already alluded to, exploring whether patients could be dialyzed via a plumbed water system in various parts in the hospital. Exploring whether we can make homemade dialysis fluids, which is common in many other countries, in order to compensate for the fact that the supply of fluids is maybe reduced. We have also established very good relationships with many other services in the hospital and outside the hospital, so that patients who are ready to leave the critical care unit can be transferred to, for instance, to the local renal unit or renal units in other places for further renal support, allowing the critically ill patients in the ICU to receive CRRT. Anticoagulation has already been mentioned as a problem. That's a clear challenge when providing extracorporeal renal support. We already know that filters and the circuit can clot easily, and that's why we spent a lot of time in the last few years trying to optimize our anticoagulation. Filter clotting, premature filter clotting was a problem, but in the last few years with the incorporation and the development of citrate and other anticoagulants, it's become less of a problem. Clearly, hemoconcentration is one of the reasons why filters clot, and the same applies to patients with COVID-19. Lastly, the fact that blood is in contact with plastic, with the circuit, again applies to patients with COVID-19. So the risk of clotting is, the risk factors are the same as in patients without COVID infection. But what a lot of clinicians have reported is that they see an increased risk of circuit clotting, an increased risk of premature filter clotting. And this is most likely the result of the hyperinflammation. So it's clear that the COVID virus, as shown here on your left-hand side, can lead to hyperinflammation, and it's called cytokine storm in a number of patients, in a large proportion of patients. As shown here in this figure, cytokine release and clotting are closely linked. And as you can see here on the right-hand side, the risk of forming a clotting essentially goes hand in hand with inflammation. So formation of clots has been reported in this patient group, but also formation of a protein cake, so-called clogging, is frequently reported in patients receiving renal replacement therapy. Just for information, membrane clogging this refers to the formation of this protein cake, and the consequence is impaired permeability and impaired ultrafiltration across the filter. This is in contrast to clotting, which again also occurs more frequently in this patient group, and this results in impaired flow. Both problems are frequently seen in sick patients with COVID-19, especially in those who are hyperinflamed and vasodilated. The prevention and treatment for this consists of anticoagulation, which will obviously prevent clotting, and to prevent clogging, most clinicians at the bedside try to reduce the ultrafiltration rate, try to reduce the pressure across the filter, the membrane, and occasionally switch from hemofiltration to hemodialysis again to reduce the buildup of protein. But undoubtedly, filter clotting still occurs, and anticoagulation and sometimes newer forms of anticoagulations are required. These are the currently used forms of anticoagulation, and in a lot of units, regional anticoagulation, i.e. citrate, where only the filter was anticoagulated, was common practice. It's become clear from talking to colleagues and also in our own practice that citrate alone may not be sufficient, because we've seen clots forming in the circuit, so not just within the filter. And in some clinicians' practice, including our own, we've changed over to systemic anticoagulation with heparin. Anticoagulation is important, but does not substitute for good vascular access. And I want to highlight this because none of the anticoagulants will work if patients don't have an adequate vascular catheter. And it's important to remember that the catheter needs to be of an appropriate length and appropriate diameter in order to facilitate and allow appropriate renal replacement therapy. And I want to highlight this paper by Thomas Rimmele, who elegantly pointed out the importance of catheters. It's the length and the diameter which are important to allow adequate blood flow and prevent the formation of clots. Lastly, is there anything else we can do? Well, clearly, if we prevent AKI right in the beginning, then less patients need renal replacement therapy. And it's important to remember that. We may also be able to delay the need for renal replacement therapy, especially in those who receive intermittent renal replacement therapy, by encouraging urine output, for instance, with loop diuretics, by preventing fluid overload, by minimizing the fluid intake, or by other forms of reducing the risk of hyperkalemia, for instance, the use of low potassium feeds. These are the really medical conservative ways of ensuring appropriate renal support to those suffering from COVID-19. A lot needs to be learned in the next few weeks to make sure that patients who need renal support also receive this therapy in times when supplies and resources may be tight. In my last slide, I just want to briefly mention blood purification. And clearly this is a question because, as I've already said, in a lot of patients, the disease is associated with cytokine storm. And the question is whether some of the organ manifestations could be prevented by, for instance, filtering or absorbing some of these cytokines. Professor Ronco and colleagues elegantly described the rationale for extracorporeal therapies in a very recent review article. And they elegantly describe that there may well be a role for the removal of cytokines. And I know from personal communication that blood purification was used in some units in other parts of the world during the COVID pandemic. However, this has not been studied in a formal manner. It has not undergone any randomized controlled trials, and the evidence to date is based on personal communication and personal experience and case reports. So much more needs to be done. But clearly there is a rationale for exploring this. So in conclusion, I'm afraid there is no universal plan for renal replacement therapy in COVID-19 patients in the intensive care unit. The circumstances can change quickly, the medical condition can change quickly, and preparedness is essential. And in my opinion, the most important weapons are working closely with your colleagues, learning from each other, and building up resilience in order to cope with the challenges this disease faces. So, in conclusion, guidelines suggest standard renal replacement therapy, but I think as we get more experience, we will hopefully identify the best ways of providing renal support and overcoming some of the challenges, including clotting and clogging. We will hopefully still be able to provide renal support where it's required, despite limited resources and supply limitations. And we will all learn more about the role of renal replacement therapy. Thank you very much for listening.
Thanks very much, Marlies. So another virtual clap for you. There's unsurprisingly hundreds of questions. First one is, don't forget to turn your microphone on when you want to speak. Oh, no, that's for me. Right, so we'll go on to the next question. Regarding anticoagulation, should we use heparin on a regular basis, considering the pro-thrombotic state?
So it's a good question. So in our hospital, working with the hematologists, the current recommendation is to use systemic heparin only in patients with a confirmed DVT. But we're currently reviewing our own practice and are wondering whether we should have a lower threshold to use systemic anticoagulation.
Yeah, it's interesting. You know, some of the Chinese data, I think, showed that the incidence of DVTs was actually quite low, but central clot and arterial thrombosis were quite high. So, you know, it's like many things with this disease, normal rules almost don't apply.
Mm-hmm.
Yeah.
Right.
Let's have a look. There's some other questions about PD, which of course I have very little experience with acutely. Someone's asked, is it a realistic option for patients who need frequent proning? That's certainly something that, you know, I've considered. Also, the fact some of our patients are in excess of 150 kilos. So if you're 150 kilos and proning, what do you think about PD there?
So I think acute PD has a role, but I'm not sure whether I'm concerned. I don't think it has a role in the very acute phase where patients are being pruned. But I believe that it may have a role in those who are recovering, who are maybe weaning from the ventilator, who are in the recovery phase, but not quite ready to leave the intensive care unit, but still requiring renal support. And that's certainly where we are potentially considering PD. So those who are hemodynamically stable enough, who don't need to be turned and are on course to the renal ward. If we use PD in this group, then we would free up machines for the people who actually need it more urgently.
Yeah, that's a really good point. I think it's a bridge to the ward, if you like.
Yeah, I agree.
Acute treatment. There's one really good question here that's a comment, really, and I must admit it's something I was discussing just this morning. And they said, given you may want to remove fluid, would it be viable to use a modified ECMO circuit with a bridged hemofilter in order to provide scuff?
Yeah.
Yeah, exactly. I think that's quite a good idea. And in fact, because you're an ECMO unit, you've probably seen them do that, haven't you?
Yeah, it's a good idea. And interesting, as you face these challenges and you talk to people, you learn about so much. I've learned so much more about renal replacement therapy and new techniques that, yes, scuff is an alternative, absolutely.
Okay. And, unsurprisingly, there's quite a few comments about some of the hemoperfusion type filters, such as Cytosorb. There have been a lot of questions about that. You got any comments on that rather than just the last few slides?
I have not used any of the devices, hemoadsorption or hemoperfusion, but I do know that people in in China have used them. I also know that people in Italy have used them. As far as I know, I'm not aware of a randomized controlled trial in this patient population. Intuitively, I can see the rationale. I understand it, but I have no experience, and I think it needs to undergo some research before we recommend it. But it makes sense to me. I think this is it's a group. They are potentially hyperinflamed with major intravascular problems, inflammation, clotting, and so forth.
Okay. And there have also been a few questions about timing. Talking of which, I've just checked the time, and we're past 1500, but we can go on till 10 past. So, given the fact that in many cases, certainly in the initial stage, people were using filtration for protecting volume status, if you like. Do you think that the introduction of RRT in this group is different and should be done at a different juncture in the illness compared to a patient with sepsis, for example, or true sepsis, or a trauma case, or whatever? What do you think?
It's a good question. So, for a start, at the moment, we're still waiting for the results of the START AKI trial, but we've had 3 randomized controlled trials, of which 2 showed no advantage with early initiation, and a single center study showed a survival advantage with earlier initiation of renal replacement therapy in a particular patient group. In the sub-analysis, in these trials, there was no advantage with earlier initiation in patients with sepsis. Having said this, when in the beginning, in our own clinical practice, we started treating these patients like ARDS, and in the pulmonary edema, and we kept patients very dry. This has changed completely in the last 3 weeks, and we are now starting patients on renal replacement therapy when they meet absolute criteria. So hyperkalemia, refractory fluid overload, or complications of uremia. And we do no longer start them to prevent the development of pulmonary edema.
No, that's yeah, that's it's really interesting, I think, and that's exactly mirrors our experience. Now, I don't know, is Eric still there? Can we have a kind of holy trinity?
Yes, I'm here.
So what I was going to ask you is, a few people, just as we finish off, have asked about biomarkers and the role of biomarkers in predicting what may be pre-renal or super dry patients, or something else going on. I mean, what do pair of you think? Do you think they've got a role? Or?
I personally think they have a high role, because we don't understand this disease. There are so many. So biomarkers essentially are physiological markers, so they tell us something about the condition of either the kidneys or the endothelium or the blood vessels or so. But we're still at the beginning of understanding this illness, and I think as a minimum, the biomarkers will hopefully improve our understanding of this illness. They may hopefully also give us some additional information of development of AKI or recovery or so forth. But at the moment, we still need to understand the illness, and I believe biomarkers will help.
Okay.
Yeah, I agree. Also, it's too early to include biomarkers as a given fact and as a therapeutic. If the theory on COVID initiated cell death is true, all patients should have positive biomarker readings, and then it loses a little bit the impact it has in the differentiation between pre-renal and or dry patients versus patients who already have damage to the kidneys. So,
yeah, I suppose what it could do, Eric, is highlight the patients at highest risk.
Yeah.
But there seem to be some, and certainly in my practice, and I know Marlies, that no matter what you do, they don't get AKI. Whereas there are others that, you just give a nudge to, and they suddenly end up on a filter. So it may be that biomarkers can predict that early. I'm not sure.
It could be an additional tool in keeping the patients dry or not.
Okay.
Yeah.
Right. Well, I think that's probably draws us to a close. Now, my colleagues at work have been texting me for me to give them a tune on my guitar. But
Excellent.
Don't worry, I'm not going to. All right. So that will have to wait for another webinar. Thank you both very much. You're great friends of mine, and that works really well. And you're completely on top of this. And I look forward to seeing some of this stuff in press for us all to read. Okay. And thanks for ESCOM for organising the event. And I wish you all good luck in looking after these patients, but most importantly, as the community, stay safe.
Thank you.
Thank you very much.
Thanks. Bye.
Bye.